California Master Plan for Aging and Caregiver Equity Roadmap and Strategy. And our speakers are Sarah Steinhausen, who serves as the Deputy Director of the Division of Policy, Research, and Equity at the California Department of Aging since January of 2022. Previously, she was at SCAN Foundation as a Director of Policy and Aging and a Senior Policy Advisor. In 2005, I think when you were still in high school, she was an Assistant Secretary at the California Health and Human Services Agency, and she obtained her Master's of Science in Gerontology from USC and her bachelor's degree in history from Connecticut College. Along with her is Donna Benton, who is a research associate professor of gerontology at USC in the Leonard Davis School of Gerontology. She received her graduate training in clinical psychology from the California School of Professional Psychology and was a Gero Psychologic Postdoctoral Fellow at USC. She is the director of the USC Family Caregiver Support Center and the Los Angeles Caregiver Resource Center. She has over 30 years of experience in providing direct service, advocacy, and programs for families caring for persons with dementia. She was appointed to the California Master Plan for Aging Stakeholder Advisory Commission and the California Commission on Aging. Her research focus is on the development of online evidence-based interventions for family caregivers to improve mental and physical health and well-being and to prevent elder mistreatment. She also serves as a mentor to students interested in advocacy for caregivers. I can't think of two better individuals to give this panel to us and to teach us today. I want to thank you for making the effort to join us. Your thoughts. Thank you.
Great. Thank you so much. There we go. Hello, testing
They're
here.
gonna be better with the technical.
Thank you so much, Carol. What an honor to be here, and thank you, Christina, for facilitating all of this presentation. And what an honor it is to be here with my colleague Donna. We have the pleasure of working together on many things, and I knew her way back when in grad school. So little did I know, you know, that I would be working with the Donna Benton someday. So we are prepared to make this an engaging conversation. So we're going to kind of like go back and forth through our slides. Donna and I, you know, Donna is one of our lead stakeholders on the Master Plan for Aging. So she has a really important perspective in terms of how she's elevating the issues that caregivers face in the intersection with public policy to advance our Master Plan for Aging. And then I'm going to talk to you a bit about the work that we're doing, what the California Master Plan for Aging is, and specifically focusing on the elements that intersect with caregiving. All of this is so important. The work that you all do is so important. I love how you all are focusing on the intersection of research and policy. I think all too often we see that policy is totally divorced from research, and then we're not really incorporating the important work you all are doing into actually informing smart public policy. So so appreciate all the great work you do, and I loved hearing about the background of all of the new scholars. I kind of feel like I'm very underqualified to be here right now. But anyways, great to see you all. Okay. So we're going to first, I'm going to walk through kind of the context of what the Master Plan for Aging is, and then talk a little bit about the goals of the Master Plan relative to caregiver issues and family caregivers, supporting family caregivers. We're going to talk a little bit about our stakeholder engagement efforts, and also talking a bit about California's caregiver system and how that ties in with the Master Plan for Aging. So Donna and I will be going back and forth on that. We'll talk about our next steps, and then really just want to hear from you. Please raise your hand throughout. Feel free to jump in, add on anything. We want to, again, make this as conversational as possible. Right? Is there anything you want to say, Donna, before we start?
Before we, I know we haven't even started. But, you know, I think what's
what we really want is that engagement. So as you're listening to something, if you don't understand, but particularly how you want to see research involved with public policy, because we don't get to do that very often. And so this is really exciting to have this opportunity today. So, and then Sarah is so good. I mean, with the master plan for aging, she was the person that put it together. You know, we talked and then Sarah went back and wrote it all up in real language.
Well, thank you,
Okay,
Bonnie.
anyway,
You're very nice.
She
But
promised to sing and I'm gonna do
yeah,
the
we're
dance.
usually just make this very engaging. Just kidding. Very from singing. You do
Or
not want
dancing.
that. Or dancing. Okay. So here we go. We're gonna have fun. Okay. So, I don't think I need to talk to all of you about what's driving the master plan for aging and the demographics, because that really, I'm sure, is something that you're all very familiar with in the work you do. But just a few key points to kind of underscore the importance of why a master plan. What's amazing is our research team, which I'll talk to you about in a bit, has put together some really excellent charts that really hone in on and reinforce the population aging and the demographics of it. What's amazing that if you look across the state between the years 1980 and projected out to 2060, you have upwards of 400% population growth of the 60+ population in some areas of the state over that time period. What is also really interesting is that, you know, a lot of the really critical home and community-based services that serve people at home and in the community as they age, including our caregiver system, support system, was developed in the 1980s, but nobody was really thinking, oh gee, let's plan out for what we might need in a California that's much more diverse than it is in the today in the 80s, and what we will need to consider as the population ages. It was more just a point in time, develop the programs without an eye towards kind of holistic system planning. And so now we're in a situation where we really need to think about that. And we really need to think about the fact that not only is the population aging, but it's becoming very diverse, which is, I think we need to see as a real gift to this state. It makes us much more richer as a population. But with that, we need to ensure that our services and supports are culturally responsive, that we have language access, that we are ensuring that all areas of the state have access to these programs and services, inclusive of all of the needs of our race and ethnicities. Donna.
And also, because of the diversity, we also need to understand that there's gonna be a diversity in health because of health disparities that have occurred over time because of systemic racism and how systems were set up based on policies. This diversity is not the same, you know, the diversity in terms of health and the aging experience is not the same for all of these populations and where they live. Because that's another part of diversity that sometimes beyond ethnicity, we also have to look at where people are living in terms of rural area, urban areas, and what are the services that have been developed and are available in those areas.
So that is such an important point. And just a side note to that, our research team we've been trying to think of how do we quantify that? How do we quantify greatest social and economic need? We actually have been able to do that by county, where we look at a number of factors, whether it's, you know, rural issues or people who live alone or people who speak non-English speakers, you know, all of the different factors that feed into social and economic need, poverty, housing access. And we're able to show which part of the states has the greatest social and economic needs. So,
Yeah, and we know they all intersect.
yeah,
That's the,
exactly.
you know, it's not this.
Right. And then we need to think about, okay, so how do we line up the services and supports to meet the greatest social economic need? So unfortunately, as people age in our state, we also see increased poverty levels. So you can see that when people are between 60 to 64, the poverty rate is about 14%. And then as they age, over age 75, it increases to 22%. And really what we're trying to look at is addressing this issue of affording aging. This is part of our master plan for aging, but it has to do with the fact that costs are rising. Older adults, obviously their incomes primarily are fixed. And then we see a particular challenge right now with the issue of housing and homelessness and growing population of older adults who are first-time homeless, which is a tragedy. And it's really because of the high cost of living in our state. But there's a number of other factors that go into poverty status of older adults, including the cost of long-term services and supports, which, as we all know, Medicare doesn't pay for. So just a number of factors that we need to consider.
So people losing their housing because of medical debts.
Okay, so now that all of that said, there has been a call there have been stakeholders over sure, go for it.
How many people here have actually seen the master plan for aging? Okay, not enough of you are going online.
No, this is good though.
See?
My theory is that we normal people don't need to think about the master plan. We just need to ensure, but all of you do, because you're not normal people. You are researchers. You are people that need to be engaged. And we'll tell you how you can get engaged. So thank you for that question. But as a society, we've asked this question to ourselves, like, does the general public really need to know about the master plan for aging? Well, not necessarily. We need to make sure that the master plan for aging goals are realized so that people get what they need, but we don't necessarily have to have a whole like general public walking around talking about the master plan for aging, but all of you do,
So this is why we have to go over all the goals.
Exactly.
They don't know it.
Exactly. So what happened over the past several years, I would say for the past 15 or so years, there have been some stakeholders that have called attention to the need for a plan, because demographers have known that the population is aging, and then some stakeholders were like, we really should do something about it. But typically at the state level, they're like, we'll deal with that problem when it comes to us. We have too many urgent issues to deal with right now and today. So I'm sure you recall several efforts. Some legislators called for a plan. There was a strategic plan for an aging population in 2000 that Senator Vasconcellos put together. Do you remember that?
Yeah.
And it was great. It was a great report though. And guess what? It was a report that UC Berkeley wrote, I believe.
Yeah.
Guess where it went? On the shelf. Boom, bye-bye. Great
Except for
data.
that chart that everybody.
Oh, there's a great chart. But
Yeah.
yeah, there was another,
There was this great chart that they turned into a periodic table,
yeah.
and the periodic table,
Yeah.
isn't that the?
That was from one of the studies, but
Okay,
yeah.
But other than that, nobody used that
Right.
report.
Right. So this is the thing with research. There were many reports written after that one. There was a Little Hoover Commission, which is a state body that looked at it in 2004, 1994, 2000 and sometimes early 2000, then
Yeah.
2006 or so. And then they did another look in 2011 or something. And then the legislature did another report, lots of reports. And everybody was like, oh, for God's sake, stop talking about these reports. And it's all these academic exercises that are getting us nowhere. So then there was a big movement, and there were some people, I was at the SCAN Foundation at the time, and it was our top priority, is to get the state to commit to a master plan for aging. And it fell on deaf ears, and the stakeholders were really sick of hearing about it. And they were like, will you guys stop talking about your master plan for aging? It's a waste of time. And we have other more critical things to focus on. But what happened was, there was this kind of shows the value of strategic communications with policy. There was an alignment between West Health and the SCAN Foundation to support a policy campaign called We Stand with Seniors that targeted the gubernatorial candidates. And then it was candidate Newsom versus candidate Cox. And they went to both candidates and said, will you pledge to stand with seniors and do a master plan for aging? Well, who's gonna say no when they're, running for office, right? Governor Newsom happened to be going through the caring of his own father right then, who was struggling with Alzheimer's. And his father ended up dying that fall. So he really was moved by this experience. And he said, no, this is something we need to do. When he was elected, he did commit to doing a master plan for aging, and we were thrilled. He announced it at the State of the State, and then he followed up with a executive order in June of 2019. And at that point, there was no resources put towards the development of the plan, but a lot of the foundations supported the state efforts and did contribute some resources. Then there was substantial stakeholder input and engagement that Donna was, one of the leads on, and we worked together on many parts of it.
And we had, I mean, this may just, it's not research, but this is how it gets done from a legislative standpoint. So when we got together, I mean, it was a huge stakeholder committee. There were like 45 of us or more. Yeah. And do you notice that date from when we launched? Does that look
June
familiar?
January 6th, 2021 was the day the MPA was launched. Literally, as they're doing the press conference, the Capitol is being raided and the insurrection was underway. It was a
Plus,
great time.
there was a COVID epidemic.
COVID, that's right.
And so we got started, but the group, we have been so hungry for this that we, instead of all the in-person meetings, we shifted immediately to Zoom and we kept going throughout COVID because this group, we were so hungry to have this done. And then eventually there were 2 big reports. We had to have one within the first 6 months. Was that the LTSS? The first 6 months, you had one that was on long-term care services and report, and then we had another 6 months to complete the full master plan. There were the stakeholder advisory committee, of which I was part, and then they were, every department in the state sat down and also talked about what they were gonna commit to in their department. So what this really meant is transportation, housing, Department of Healthcare Services, all the departments committed to looking at what they did in aging and how they were gonna contribute to this plan, which is very unusual to have that across departments.
Right. So the stakeholder engagement was critical because they really did work. So that's our big thing, is getting stakeholders to do the work. They submitted recommendations to the state. The state took all those recommendations and tried to build it into the final plan.
They gave us good sandwiches.
Yeah,
For a while.
exactly, for a while. And the final plan didn't include every single stakeholder recommendation because the state has to consider what's feasible and doable and politically, all that stuff. But anyway, so as Donna noted, we really had to focus on having a plan that was inclusive of the range of issues that older adults face and their needs. So first goal being housing for all ages and stages, which includes age and disability friendly communities. Second goal is reimagining our healthcare system to be much more person-centered and responsive and integrated across healthcare to long-term services and supports to social determinants of health. Goal 3 is really shifting the paradigm of how we look at age and disability, focusing on inclusion and underscoring with everything with equity to really target the populations most in need, and to really fight isolation that we see all too often as people age. Equity really is something that we've tried to make a cornerstone of all of the goals. So it's called out in goal 3, but it's really woven within throughout. Fourth goal is caregiving. So this is focused squarely on supporting both the paid direct care workers and the unpaid family caregivers. As you know, there's a little under 5 million unpaid family caregivers in the state, which is what we're here to talk about today, and how the master plan is trying to address those needs, in addition to the paid direct care workforce. And then goal 5, as we mentioned, is really focused on how you can fight senior poverty and what are some of the things we need to do to ensure that as people age, they can afford a decent standard of living. Oops. There we go. Thank you. So just quick high level overview, and I'm going to turn it over to Donna. In the master plan for aging, we update the master plan every 2 years. So this is reflective of the initiatives in the master plan right now that were revised in 2023 and 2024. So it's every 2 years, we have a new round of initiatives to keep it live. This last 2 years, we've been focusing on really looking at the issue of data and making sure that there's a streamlined way to assess caregiver needs and develop the metrics for equity. So that's some of the work we've been doing in that space. Looking at unmet needs across the state. As we said, we know that not all people are able to access the services they need. So we're doing this comprehensive gap analysis of home and community-based services, where we look at the gaps And then we're going to build a roadmap out front based on where the gaps in the system are. So that's a study that's going on underway right now. We also we did a workforce initiative. Many departments did a workforce initiative with limited funds that were given by the federal government through the American Rescue Plan Act. Actually, we developed a program called CalGrows, which was focused on training direct care workers and family caregivers with incentives and stipends. And Donna was one of the grantees in that program. We won't talk about all the trials and tribulations of what it takes to launch a state program in a very short time, because we don't always do things quickly at the state. Not because we're sitting around, but there's a lot of there can be a lot of bureaucracy, just because that's how it goes. So, but through all that caregiver training modules that have been developed by about 78 grantees across the state, we are developing a compendium of resources based on the trainings that we now have from the grantees. And then finally, which we'll talk a little bit about, a caregiver equity roadmap and strategy. So again, with the focus on making sure that we can serve the highest needs populations and really reach the caregivers that need support. People don't self-identify as caregivers and walk around and go, hey guys, I'm a caregiver, how are you? But they just do it, right? I'm sure you all know this. This is what people do. How can we ensure that the programs like those that Donna oversees are reaching those most in need and that we have the infrastructure to do it? That's kind of some of this effort to develop a caregiver roadmap.
You notice I'm not helping her.
Yeah, I'm gonna have Donna talk a little bit about really looking at caregiver diversity and what that means for what we need to do for the equity roadmap.
So before I start, or before I go on with diversity, how many people here either think you're a family caregiver or you're not sure? How many people think they're a family caregiver?
Doesn't have to be full-time either.
Yeah, it's not.
Like if you help
full-time.
out with any family member and.
Yeah. How many people are unsure if you're a family caregiver? Which is not unusual, because how many of you really think of yourselves as caregivers as opposed to an adult child or a spouse? If I said, oh, you're a spouse caring for your family member, you're more likely to go, oh yeah, I do, or I'm helping my grandmother or something like that. This is why it's so difficult to even do research in this area, because you can't go out and do a survey of family caregivers, because you're not going to get very many people in your survey. So when we talk about caregiver diversity, we have a couple of key things that you have to think about. Besides racial and ethnic diversity, we need to look at economic diversity, because one of the things that research has actually shown is that there are different out-of-pocket costs for family caregivers. And Latino and African Americans have higher out-of-pocket costs. So it's somewhere around, and please don't quote me, since you're researchers, you can actually find the real articles, but it's somewhere around $6,000 out of pocket on average when you put everybody together. But for Latino and African Americans, it's closer to $10,000 to $12,000 out of pocket costs. These are unreimbursed costs for families that are working. So there's an economic difference. Now, everybody across the board can become a caregiver, but the demands are also different. And that's not surprising, because we look at health disparities. We know that for Black and brown populations, again, they're going to be caring for people who are sicker and have more complicated needs for care. They also are more likely to have caring for somebody who has a higher risk for any type of dementia, and they may not have access to resources in their area, or they may not know about the resources and how to navigate the systems. So besides financial differences, you have these demands of what the caregiver needs. You also have different cultural attitudes about healthcare and delivery of services. But sometimes when you're dealing with the highest need population, which is our dementia population, different ethnic communities may see the person with dementia. Some may think that it's not a physical problem, but a more of a real mental health problem. So they may think that the person has a mental illness as opposed to it being a dementia or disease. You also see that people have different values, as in, I'm going to care as a caregiver, I'm the only one who can care for my family member. And they're less likely to say that I want some type of help or that I need help from the outside. So they're going to take on that responsibility. And interestingly enough, when you do use everybody probably knows the Zarit burden scale. Burden scales are lower in ethnic populations, Black and brown communities compared to whites. But does that mean that burden is lower? It's how we're measuring. This is where you come in. How are we going about measuring what people need? Because when you ask them about stress and strain and financial impacts, it's actually higher. But it's how you talk about it. If you use the word burden, you're not going to get anywhere. So right there, when you have a lot of things that are asking about the burden, as opposed to going on the positive side and then talking about what do you need for resources, it's how we're measuring it. So yes.
There's a
Yes,
question.
great. Yeah, please.
As a newly identified caregiver, when you talk about doing, like, you can't do a survey, I think even if you were able to do a survey, I don't know if people would even know
Right.
what they need or that they need anything. Like, I was sitting here thinking, well, what would I need? I don't know. Stress and strain, absolutely, right? But like, how does that translate to what I need to check off in terms of what support they need? Like, I wouldn't even know.
You don't even know what you don't know, right?
Yeah.
And it's like, we're trying to do a whole awareness campaign of how to help raise awareness of that people actually are caregivers. Because if you don't measure it, you don't define it, you can't document that there's need and that you have to do something to change the system.
Which then goes to policy.
Right, so there's the connection with policy. One thing also, just to add on in terms of caregiver diversity, is, you know, some caregivers are now being asked to do more and more. I know that when my mom was transitioned home from the hospital, I was like, how in the heck are we gonna be doing this massive wound care on her leg that was subject to, you know, it had like this wound vac, and I'm like, oh my gosh. So more and more people are being sent home with higher acuity needs. And so we find that family caregivers are totally stressed out and feel like there's nobody to support them. And so you might have, you know, somebody caring for a person with dementia who doesn't have any acute medical care needs, but their needs for support are much more different than the need of a person whose parent just was transitioned home after a hospitalization.
But I think what you were saying about the burden, the use of the word
Yeah.
burden, I mean, so, you know, so many ethnic or cultural, you know, backgrounds, they don't want to use that word burden.
Exactly.
For them, it's their
It's offensive,
responsibility, it's an intergenerational kind of responsibility, so
Right.
you wouldn't dare call it a burden, right? That's not.
That's
what it's
absolutely
supposed to
right.
be, so.
Right. But our main measure is called the Zarit burden scale.
Yes, yeah.
So, and, you know, kind of going back to what you're saying, if you don't know what you need, that again speaks to policy and how we need to have, programs that maybe pay a little more for outreach and are allowed to do more outreach, but outreach is usually paid the lowest. Absolutely not paid for, not understanding how you have to build trust in the community. So research that can show the importance of taking more time in trust building is
Yeah.
valuable research to let policymakers know that if you're going to be reimbursing programs, outreach is a very important part of that reimbursement, as much as when you are doing direct, what they call the more direct service. But you have to spend, you know, allow for those costs. And they're measured very differently. I mean, I run the state program and the federal level, what's called Title III program. And I know, you know, because I look at what we get paid, the outreach is at $13. That's not minimum wage.
Right, so I love that point too, because Donna, as a stakeholder who's connected to state policy and a researcher, really gets what we need to make our case for system change at the state level. That's why
How
we need you engaged. We have about 20 minutes or so, so I think. But we want more questions. So that goes along to what Donna was saying about our system of caregiver resource centers and funding that's also supplemented through our area agencies on aging.
So has anyone here heard of the California Caregiver Resource Centers? Okay, one
Oh,
person.
two,
Two.
three.
Well, yeah.
Of course,
Yeah.
Michelle.
I'd be scared. I know. So let me tell California and really quite, this was, who was 1980, so that was Brown.
Mhm.
First time around.
Round one.
Gary Brown, round one, actually signed into legislation the California Caregiver Resource Centers, which came out of advocacy by two women who were caring for, one's husband had a stroke, the other one had dementia. And when they, their early advocacy days, and they had said that when they went to get care for their spouse, no one ever asked about how they were doing.
Mhm.
That was their whole, and so as they were talking to friends and others, they said, we need a way to have somebody ask about us. We need things like support groups. We'd like to have somebody tell us in an easier way how to find resources and help us navigate resources. We'd like to have a break every once in a while. I love being with them 24/7, but can you imagine working all your life without a vacation? And they had gone already 7, 8 years without a vacation. So, they piloted the program out in San Francisco, which was Family Caregiver Alliance. And that was the first Caregiver Resource Center pilot that then was expanded to 11. There are 11 Caregiver Resource Centers that cover all of California.
You can see them up there.
You can see them up there. I do LA, which does include Catalina, but I still haven't gotten over there. But Los Angeles, so that's LA County, but you can see some have multiple counties that they cover. And the program is really based on what people, you kind of think of when somebody comes into the system, they don't have to go anywhere else, and they're gonna have an assessment that leads to a care plan, and then the people are able to stay with you throughout their caregiving experience, which in many cases, because the caregiver resource centers deal with all types of dementia, so that includes traumatic brain injuries. So that means that we could have a caregiver who's caring for somebody that had a TBI from the age of 20, 25. You can have Parkinson's, you can have ALS, clearly a high percentage just are people with Alzheimer's disease, but you can have stroke, and these, you don't go in and out of the system. You keep the person in the system and you do reassessments and you stay with that person. And because the needs are gonna change, maybe in the beginning, they just need a little guidance. But as the person's disease progresses, they may need now financial to start setting up their long-term, care and knowing how to set up financial things. They may need more counseling, direct counseling, because maybe they start getting depressed. With our measurements, because we use a standardized measure across the state, so no matter where you go, you get the same assessment. We find that about 50% of the caregivers have symptoms of, depression, and we look at anxiety. We do a shortened burden scale, which we don't call the burden scale. We look at isolation and loneliness, and we've actually, over time, the comprehensive assessment has changed. But then that leads to the care plan, and then they get a family consultant. And that's that personal care navigator that stays with you throughout the time. And some people just need it for a little while, then they go away. And we have about 35% of people come back after several years. We have some people, particularly who are caring for someone with TBI, they've been with us 10, 15 years. So it's a lot. And so we do the differences across the state are based on, because people are in urban, rural areas, so you're gonna have different resources, different education and training programs. We do a lot now more statewide level trainings in varied languages. and with, on different topics, because diversity has changed, so I have more Spanish speakers in my area than say up in, Tulum County. There might be a smaller population of Latinos up there, but it's harder to put on a program for Latinos for the smaller population that they have. So that when I put on my Latino program, we use Zoom now,
Oh, that's so
and then they
cool.
can come into that program, and then, but they're still connected to their local CRC. So they still have their local person, but they can get the larger education, meet other people throughout the state. So we have, I think last month, on average, we're putting about 45 education programs a month that are in varied languages. And that's the beauty is we can share across the system with languages. So that's the Caregiver Resource Centers, and we were the first ones in the US to have this type of state, and still continue to be the only ones with the actual statewide system of Caregiver Resource Centers. Then in 2000, the federal law was passed, which is called under the Area Agencies on Aging, under Title III-E. And that was based off of the CRCs, but now all states have some level of family caregiving, but they don't do it integrated like in California.
And if you think about it from a policymaker's perspective, not only is this the right thing to do, but it makes sense, because if you can support family caregivers in their role, they're less likely to just give up and not get what they need, because then what happens? That person's more likely to face long-term institutionalization, which is bad for the person. It's also bad for, you know, our systems like Medicaid and Medi-Cal and all that.
And
So
the reason, there are at least a few studies that show that systems that are kind of holistic, have a better outcome when you're able to support the caregiver, because if you don't support the caregiver,
Yep.
you know.
I'm just curious, so the funds come exclusively from the state?
Yes, for
Is
the
there
Caregiver
capacity
Resource
for
Center.
private foundations,
No,
or so
No.
it's completely?
this is your tax dollars at work.
Right.
So
General
when you
fund,
need
sure.
something, all you people that, where you raised your hand and said, I'm a caregiver, guess what? You can use the
Yeah.
system.
yeah,
There's no
the federal
income
funding is the one that matches it through the Area Agencies on Aging. That's funded through the Older Americans Act. But yeah, and we're always trying to get more money for the Caregiver Resource Centers, but we need to, yes.
But how is that initiated? So how does one find out about the resource centers when the provider's not mentioning that? Or perhaps you're not already hooked up to other networks that could potentially let you know about this? I mean, I never heard of this and I was caring for my mother. So my interest is, where does that kick off? Who is gonna initiate the conversation to tell you, regardless of your ethnic community, because there are differences? And who are you gonna trust to give you those referrals and resources and say, this is what can help you, and in your language and in your kind of need?
Yeah.
Where does that kick off?
Yeah.
Where is the magic hook?
Oh, boy. You're getting one of the big issues that we're trying to address through the master plan for aging, which is how people navigate the system. How do they even find out about services and support? So it's called, we're working on developing a no wrong door system, which includes like a consumer facing statewide web portal and live help contact center that we have to do the marketing and the outreach for it. It has to be culturally responsive, and we're developing the plans for it. But the idea is, if you're at a doctor's office and you all of a sudden you're with a friend that gets a diagnosis of, say, dementia, usually what happens is the doctor's like, I don't know, just go home, and if you need help, maybe call home health. Like, literally, that's it. They don't say, contact the Caregiver Resource Center, contact this. But if they know, oh, you know what, there's CalCareNet, I'm just making that up, that used to be it. Go to calcarenet.org, and this is the 1-800 number, and just all people would need to know is that. Or you might be at your local county department and they know about it and they refer you to it. So there's ways to do it. Some counties have done it better than others, but to your point, we have a long way to go.
So I see a quizzical look, because let me guess. We don't all trust the doctors, and that's not necessarily a trusted resource. Is
No.
that part of your look or something else?
Or community.
I work in public health, and so I can ask questions. I was very heavily resource informed on, and I still did not get what I needed to
Yeah.
get me started with my mother's
Right.
in-home care with me.
And that's part of that is part of the no wrong doors, that at least the larger
And a
system,
social worker never mentioned it.
right?
It's absurd.
We have to keep training, there's turnover. And we have to get the larger systems to have it on all of their databases, which is where technology is coming in. So we're looking at systems where there's I forgot, what is that system that they're developing?
Sure, or no.
No, not Charm, there's there's where they have all the resources.
Well,
to get-
electronic,
Yeah.
yeah.
Electronic health records that then link to, yeah.
Yeah.
So
Data
that,
exchange framework.
there it is, the data exchange. So the data exchange framework links to all of that are trusted resources, of which a caregiver resource center would always be there. Alzheimer's Association would be there,
Back end
AARP.
of the consumer facing web portal.
So that all of these big systems would have it. But the other thing is we have to spend more money on educating, I can see, yes, we're educating different, so like for us at our resource centers, and actually a lot of the resource centers, we directly work with churches where we aren't the people doing the outreach. We've trained people within the church because they're the trusted resource. We train them to talk about caregiving. And then because they know who we are, they'll refer their parishioners to us. But they actually do all the initial outreach and discussion because you want those trusted resources. So that's a constant, yes. I think you had your hand first and then you.
I'm here as a caregiver, but also, I wanted to talk about like caregivers to the caregiver. For instance, like I did public outreach for a long time, but like I didn't realize that my daughter, who like grew up watching my mom caring for my dad who has Alzheimer's, like she suddenly, without my influence, she suddenly started a club at high school to address like loneliness and all that. Not because I told her anything, but she watched like, how lonely grandma gets. And then I'm like, girl, I don't know if anyone in your high school is gonna join that club, but then there are all the other high school kids that saw that,
So awesome.
like loneliness and caregivers. Like, so this kids were being caregivers to the caregivers. And I have to be honest, like she does better, like wellness checkup. I mean, it's not labeled. She just go like, oh, I noticed food in grandma's fridge, or I noticed she's sad that she was taking a picture.
Good job,
I
Mom.
just drop her off and I cry, and I'm like, oh, I don't wanna like get the sadness from mom too, you know? But I just realized how like information, like of course churches and formal, but if you're able to like get this idea, and then this kids, like high school kids are like, you know, they're like seeing it, and then her high school is 2,000 kids, and you know, it go on, so just the idea of like caregivers to their caregivers.
And we have to start early like you're doing because it's generational. You had your hand up and then you.
Can you walk me through your navigation portal? Because I think you have a place where people put in their information, right? Of what they need.
Here now.
Yeah, Care Now, right. And so once they fill that out, how soon does someone contact them, like a person does, or is it just like an email?
Okay.
Here's.
Perfect.
Yeah.
Yeah, we should be so sophisticated, but put in all of the information immediately. So that portal is like your physician portal that you have. So it's a, you know, HIPAA compliant portal. You put in your information and immediately it is going to populate based on the answers to your questions. You'll get resources immediately on your dashboard. The second step is that everybody after they put that in, a live person goes in, looks at the profile, and then they will be calling you to set you up for a meeting with what's called a family consultant. So you always have the option of having a real person talk to you. Some people don't want the real person talking to them, and they'd rather just interact with the dashboard. So they can have the dashboard, they can ask questions, it'll have, based on your zip code, it'll tell you what education events are available. And so they could just get that surface level of resources and information. But at some point, I think every caregiver wants to talk to a real person.
Oh, yes.
They want to be able to have that support group. They want to talk to someone about their individualized case. And even though the dashboard is giving them individualized information based on their responses, they still need to talk to a person. So they will have at least a phone call will go to them, an email will go, they'll try 3 times to actually talk to the person. But if they don't respond, they'll just keep the dashboard until hopefully the person reaches back out to us again. And we get to talk to them. You were first and then you.
So I have a couple of thoughts and questions. One is that a lot of times, I think the home care agencies have a financial conflict of interest. So they would rather have you pay for a lot of these services through them than to go to a state program. And then the other thing is there is this layer of people who are preying on older adults, especially those with mild cognitive impairment. And I think it's, when you're getting like outgoing calls to the house, I think that it's impossible oftentimes for the senior or their older adult partner, if they're still alive, to sort through kind of what's real and what's fiduciary crime,
Right.
essentially. I think for my parents, I finally had to just put red signs on every phone that if anybody you don't know calls this phone, hang up, because they were getting so much financial fiduciary crime aimed at them. So I think that makes older adults very nervous about putting any personal information on a website. Even if you say HIPAA compliant, they don't know what that means. And so, is there a way to access services in a way that is telephonic rather than through a web page? And then second, is there any attempt of putting resources into trying to get above the communication fray, with direct to consumer commercials or things like that, people can see a number and they can reach in rather than, waiting for a call, reaching
Yeah,
out.
all the CRCs have, like, I have an 800 number. And for a while, we changed to a non-800 number, and then I realized, it's like everybody had this. So if you have an 800 number, it's kind of like that old-fashioned number.
Yeah.
And people know, so we kept the 800 number. But almost all the CRCs, most of my things are coming through on phone calls first, not so much online. But it depends, because remember, our services are not for the person who has dementia.
Yeah.
We're for the caregiver, who on average is around 45.
Okay.
So we're calling back to the caregiver, not to their relative with dementia. Now spousal caregivers tend to be older.
Yeah.
But again, they've usually called us, or if they go online, at least when we're reaching back out through that portal, we try to remind them, who we are, why you called us, all of that kind of thing. Your question, comment.
A quick question, comment and then a question. As you're talking about the current steps that are going on and getting out the awareness, what came to mind was just the campaign for the suicide hotlines. And just how that's so, is trusted. One, you can see it at the end of a episode of your favorite show, right? If they touch on it. And I think one of the positive things there is that it's a nationwide. I don't know if it branches out once you call that number to your state, but are there any efforts, and I know the logistics and the bureaucracy of it all, but are there any efforts at trying to combine or at least like have a starting point that bridges out into the state?
This is exactly what we're trying to figure out right now. So the first thing I just want to know, it's resources. I think hundreds of millions of dollars went into that campaign, and I agree completely. And trying to justify to legislators the importance of resources for outreach. We had proposed 10 million towards a outreach campaign. We actually put together an aging resource guide in multiple languages, but it's of all services. That's great. That's a first step, but not everybody's going to see those brochures everywhere or know how to get to our website. This is a very, very initial first step. But the legislature, we all of a sudden were in a very bad fiscal situation. And that was the first thing to be cut, was the money for awareness campaigns and establishing the trust like you're talking about. We are looking at how we might leverage the 211 system right now. That's generally more known, but so this issue of how you establish one simple credible place to go is so important. And then how you put the resources into the outreach and the awareness campaign. The suicide campaign or prevention campaign is a really good example, but the federal and state government put tons of money. We have to make it a priority. So
Has there ever been any policy or legislation requiring, like, you know, when you sign up for home care, you have reams of paperwork and disclosures and all this stuff you have to do to start the services. Has there ever been legislation saying that home care companies have to notify people of this? You know, when I think about that folder that we got and all the information,
well,
it seems like, you know, if you
Yeah.
need home care once, you're very likely to end up.
no, it's
you
a
know,
really good question. We're
needing
trying to,
ideas.
we're trying to crack the net of how you can get the medical community, including home care, to be a better bridge with the
Yeah.
social service community. There has been, for example, there was an act at the federal level that was sponsored by AARP and that California then developed, where in the hospital, when a person's getting discharged home, they have to ask their family support or whomever it is, who the caregiver is, and actually document it on the discharge planning. But, you know, I think that's a great step forward. It's not, it's not a solution. So this is something that really, really is going to be critical to address. So I want to make sure we get to just, we'll go quickly through these slides because I really think we've hit on a lot of the really important
I
components.
mean, you started 10 minutes late, so feel free
Yeah,
to
so,
change.
so as I noted, I already talked about this.
Yeah.
We're trying to build out a roadmap that is addressing all these gaps in the system and looking at how what's the strategy for how we build out the system to reach more in need. Right now, I believe the caregiver resource centers serve maybe 11,000 a year.
Yeah.
11,000 people a year, and I said there's a population of approximately 4.5 to 5 million family caregivers. So we're not reaching the most in need. We're not reaching the populations most in need either. So we have to do a lot and continue developing the data.
But, okay, when we say 11,000,
That's not exactly.
that's not exactly correct in terms of,
I don't
those
like
are the
nuance. I
people-
don't like nuance.
I know you don't like nuance. So that is, you know, those one-on-ones, that's how many we're serving one-on-one. But when you talk about reach, then if you add in our education programs, our support groups,
Yeah.
our referrals, we hit closer to somewhere in the, I mean, some years we've had 100,000, so that's
Yeah,
probably
that's a good point.
the better
Yeah.
number to look at, because at least that means that we've had a touch point of people
Yeah.
who have now, in some way, we've helped them identify themselves as caregivers. And then we don't generally count even like education events that allow us to tell people
Yeah.
and, you know, other people, so that they now know, all of you can now know that there is a referral and there's a statewide website. There's California Caregiver Resource Centers. If you just Google, you'll find that we now have a statewide website where it's easy. You can poke on the map or you can put your zip code and you'll get to the right caregiver resource center. So we've really, that's important about understanding the reach. I think the other thing is that we are really looking at those evidence-informed interventions to help caregivers, because that's again helps influence legislation. So since the beginning, we've always had statewide evidence-based interventions. So like we were the first ones that deployed the early stress, we did stress busting statewide. We have the caregiver, what is that program? Powerful Tools for Caregivers statewide, where everybody, because we know that the outcomes address depression, anxiety. We're looking at stress, that's stress busters, which depress. So we make sure that we look at programs that at least either they're evidence-based or evidence-informed, where we can actually show impacts and outcomes to legislators. Because that's, you know, now the legislation wants to know, how are you delaying institutionalization, which is what their
Where's our
costs.
return on investment?
Yeah, what's the return on investment? But for the caregivers, you know, some of that, I think we have to get the advocacy part, which is why there is there's the California advocates for caregiving. And if you want to know how to just join the advocacy, that's what I run. So
She's a place to go.
please, yeah, please let me know, and because we need the voices of caregivers to talk to legislators, because everything can't be based on, are we gonna reduce the depression scores? Part of it needs to be in that area of, can we help people be comfortable at home? Because more and more is being pushed to the caregiver without asking them, can you handle this? Is this something, should everybody be doing wound care? Should everybody be doing lifting for 3 and 4 years? And because should everybody be being forced out of the workplace? And this is where advocacy comes in, because families are leaving their jobs, which then in turn impacts the next generation, because they won't have savings. They don't have health care during the time that they've left their employment, because remember, these are 45-year-olds. When they try to come back into the market, they're an older worker and you can't get back in. So the financial impact goes across several generations, and we have more younger people in multi-generational households, of ethnic households, that again are not necessarily being addressed by the legislative structures that we have to serve family caregivers.
Yeah, perfect. Great, so now we're gonna switch to the last few minutes, talk about how we hold ourselves accountable in this work, and this is kind of where research and data come into play. So we have a research team in our Division of Policy Research and Equity, which is what I oversee. And our whole team in the Division of Policy Research and Equity is charged with advancing the master plan for aging, but we do it in partnership with the other state departments and the stakeholders. So we're not really inward facing, we're more outward facing. Our research team has developed a data dashboard for aging, which looks at indicators across the 5 bold goals of the master plan, so that we can kind of assess our progress in the master plan. We've also developed an equity framework for how you actually define and operationalize equity in the master plan. And we're looking to build what it currently is the California Elder Index at UCLA, Center for Health Care Policy Research, which is a wonderful tool, but we want to bring it in-house so that we can update it and we can make it something that the state uses regularly to inform its own state policy. What's really important too is in terms of accountability, we have our California Aging and Disability Research Partnership, which Donna is a member of. This is one of our key stakeholder committees. The Aging and Disability Research Partnership is comprised of representatives from our higher education systems, as well as philanthropic partners and state partners, where we try and look at how we advance research and data within that master plan for aging. One of the key areas of focus was developing key outcome measures for the master plan. So not just progress indicators, but what's the outcome of the master plan? So one of the indicators, this is the picture of our data dashboard. You can go online and look at it. But these key outcomes, we really tried to extrapolate. What are 4 key outcomes that are so critical right now for older adults? One is with a rate of older adult homelessness, needing to look at what's a key outcome for how we're reducing homelessness. So we have the homeless data integration system and that data that goes with that. Reducing self-reported psychological distress among older adults and people with disabilities. We use the California Health Interview Survey for that. Reducing burdens, there's that word, faced by family and friend caregivers. And we use the California Health Interview Survey caregiver module.
Which is out of
And
UCLA.
CareNav, which is what Donna was talking about. This all took so long to develop consensus on how to develop these measures, and I know you were part of that. It's not perfect, but it's something to start with. And then we also wanted to address the issue of our paid caregiver workforce and needing to build that pipeline. So we're using census data to see if we are being effective in increasing the provider to population ratio among the direct care workforce. So just to close out, stakeholder engagement is really critical to advancing the MPA. We have 6 stakeholder advisory committees. You can learn about them on our website, one of which is the Aging and Disability Research Partnership. We're in the process of standing up a lived experience advisory board of real people from the community that either are not using the system services or are and we need to get feedback from, including caregivers are gonna be on this lived experience advisory board. Because oftentimes we're an echo chamber just listening to ourselves. We need to hear from real people. And some of the comments you provided today are examples of like, what's the real experience people are having at the local level? And how can we address that through state policy? Stakeholders provide us recommendations through their stakeholder engagement. Every 2 years, we bring together stakeholders for our big, what we call the Day of Action, where the stakeholder committees present their top 3 recommendations to inform the next round of the master plan for aging. We actually just had our event last week, which was very fun. And then now what we're doing internally is we're drafting our MPA initiatives for the 25-26 year. And we're working, it's like sausage making, because we have to work with all the state departments, get buy-in from the governor's office, get buy-in from our Department of Finance. And then magically by January, we release the new round of initiatives. And then I want to take a 10-week vacation. So that's how the process works. And we are a little over time, but if there's any more questions, we'd be happy to answer. Yep.
I think we have about 3 minutes for questions. As well.
I think we had great comments from all of you, and just encourage you all to go to mpa.aging.ca.gov and get connected.
And I also encourage you to do California Coalition on Family
Yes.
Caregiving. Google that, put your name on the mail list, at least quarterly. There's a Zoom call where we talk about priorities. One of the bigger priorities is really having that legislation around working caregivers, because that's your generation and the next generation. 2 people had their hand up.
Just a quick question. So in the website, do you have resources about prevention of financial abuse or financial fraud? I mean, that's the big
So the
issue.
Aging Resource Guide, if you go to aging.ca.gov, that's the Department of Aging website, and that does include those resources. So again, go to aging.ca.gov and then do a little search for resource guide and you'll see it. And yes, we need to do a better job of how our whole website, just ignore it for now. We're like, how can we start over with this thing? Just a side note, okay? I don't take responsibility for it.
Just a quick comment. So I'm embarrassed. I am a neurologist who knew nothing about the caregiver network. So thank you for that.
Thank you for the work you do. I loved hearing your
Yeah.
background and bio. I'm amazed.
I already put you down as one of our
Damn.
speakers. I already want you for a speaker.
Yeah, we want you to serve on our committees.
We'll follow up after.
Okay, I really do.
Just a quick comment, also embarrassingly, so we don't have a social worker right now for the whole Department of Neurology outside of one that's specifically for our dementia center right now. And so this resource and as the website and that infrastructure build will just be so helpful if I could, just like, here's this QR code and this
Right, you just
website.
want a place to send people.
Yeah, I
mean,
know, and
yes.
it's usually the questions that patients and their families ask are like the tangible resource
Yes.
stuff
Right.
Yes,
that I just don't know.
of
And so
course,
this
nor
is
should you be
really
expected
helpful
to know it, and I think we need to figure out how to make it easier for doctors, because it's not like doctors are like, I don't care, but they can't do a whole
Yeah, but I'll
long-term
share
care.
this with my colleagues. because
Good.
it'll be
Awesome.
really helpful.
Yes,
2 questions.
2 questions, and then I know she's gonna kick us out.
gonna bring it.
Where are the best places for youth people? And a lot of times, as I think you mentioned briefly, it's the discharge plan.
Yes,
Right,
yes.
and when you're sending people
Yes.
from the hospitals and other care facilities, what will it take to get this resource among their checklist of things to address with patients before they leave?
Well, we've tried with that, and some hospitals do have like a handout, but it was fascinating because I experienced this. The handout was, it was okay. We need to make it easier for them, and we need to do what we're talking about. Some do, some don't. There's been legislation, as I said, but it's not always effective, and sometimes it gets killed because they say we don't have the resources to do it. So one last question, and then I'll call it a day.
It's not necessarily a question, but with regard to the financial abuse, LA County has an entire unit that deals with older adults and elder
Sorry.
abuse
Yeah.
and all varying levels, financial,
Absolutely.
physical, emotional. So if you get a hold of the county, you can
Yeah, area agency. on
get
aging.
further information about elder abuse.
Absolutely, adult protective services and, yeah.
Yeah, wise and healthy aging, holds the contract for
Oh,
that.
that's good. Okay, well, thank you all.
Thank
This was a great.
All of the agendas, we need to invite this team to UCLA. I think much like as a neurologist, you would never heard of these resources, as a primary care doctor, neither had I. And it